So welcome everyone to our weekly orthopedic surgery grand rounds. So today we have a very special visiting speaker, Dr. Andrea Spiker, and for an introduction, I'll turn it over to Dr. Zhang.
Thanks, Dr. Lansdowne. So I'm really honored that we're able to host Dr. Andrea Spiker today here for Grand Rounds. So she grew up in Wisconsin and Indiana, and then she went to college at Wellesley. And after that, she was a Fulbright scholar in Germany. During this time, she was also a speechwriter for the National Science Foundation, which is why you'll see she's an excellent public speaker. She then came back to attend medical school at Georgetown, graduating AOA before doing orthopedic residency at Johns Hopkins. And then she did a 2-year fellowship in sports medicine and hip preservation at the Hospital for Special Surgery. After that, she was recruited back to Wisconsin, where currently she is the director of the Sports Medicine Fellowship Program and the head team position for the men's and women's basketball team. She's also the director of the Hip Preservation Program. Yeah, this is going to take a while, and that's because she's one of the few surgeons in the world who can do both hip arthroscopy and open hip surgery, such as PAOs, in an expert manner. She's had numerous research publications, and she's a lead researcher for the Anchor Group, which is a large multi-center cohort for hip preservation. She's also on the editorial board for multiple journals, the host of the Arthroscopy podcast, and she's most recently just named one of the associate editors for the American Journal of Sports Medicine, which is a very, very elite group. So she's been invited to speak at over 70 national meetings, and she's the international leader in hip arthroscopy, leading courses and committees. So in a short period of time, she's really become a superstar as a surgeon, researcher, mentor, and teacher. And in fact, at the most recent International Society for Hip Arthroscopy meeting, the board of directors unofficially named her the next most influential person in hip arthroscopy, is what I heard through the grapevine. So allow me to introduce Dr. Andrea Spiker and give her a warm welcome to UCSF.
Thank you, Alan. That was an awesome introduction. And I am so honored to be here. It's such a pleasure to meet all of you. And I was really excited to leave Wisconsin for a little bit of a warmer weather. So that's awesome. So today I'm going to speak on the limitations of hip preservation and also discuss, importantly, how we might be able to overcome these limitations. So here are my disclosures, none of which are relevant to this talk. But I want to say again, it's such an honor to be here. I thank my colleague and friend, Alan Zhang, for the invitation and all of you for having me. Alan and I have gotten to know each other over the years through courses and conferences. And then through him, I've gotten to know Stephanie Wong as well. And so, it's a great group that we have, and such a pleasure to come here and speak with all of you. So at the University of Wisconsin, and I apologize for some overlap here in Alan's introduction, but I'm in the sports medicine division. My practice is currently hip and knee sports, plus open hip preservation surgery, including periacetabular osteotomy. I'm a mother and a wife. I'm tenure track at the university, so I'm active in clinical and collaborative research. I take care of the men's and women's basketball teams. I'm the fellowship program director for sports medicine fellowship. And here you heard a little bit about my journey, but I wanted to put this in the frame of how I got into hip preservation. So I grew up in the Midwest. I was actually born at Madison General Hospital and went east for all of my education, worked for 3 years after college and would have worked for longer, except that the MCAT is only good for 3 years. And I didn't want to take that test again. So I went back to medical school at Georgetown and then stayed on the East Coast. And in residency, I saw a total of 4 hip arthroscopies. And at the time, each of those was probably a 4 to 7 hour case. So not quite what it is today. It was my first rotation in my sports medicine fellowship that was the hip arthroscopy rotation. And this is where I really got turned on to the fact that perhaps hip preservation is the final frontier in medicine. And there's just so much that we don't know and so much that changes very rapidly. And so I decided during my sports medicine fellowship to forgo working that next year and instead to stay on and do a second year as a hip preservation fellow. And then now back at the University of Wisconsin, I've developed the hip preservation program, and I actually take trauma call at Werder is what the hospital is called. That's the hospital that I was born at. So today I'm going to break the talk into two separate sections. First, I'm going to talk a little bit more on the technical side. What is hip preservation surgery? What can we accomplish with hip preservation? When is it clearly not right for hip preservation? And then when are the situations that we don't know for certain? And this is where it's really important to understand our limitations. And then I'm going to discuss big picture. So I'm going to talk about the losing battle we have with the total hip replacement, the learning curve for hip arthroscopy and periacetabular osteotomy, patient-reported outcomes, and then diversity, equity, inclusion in orthopedics, and especially in hip preservation. So first, what is hip preservation? The simple answer is that it is the interventions, both non-operative and operative, which maintain a patient's native hip and delay or prevent a total hip replacement. So first, what can we accomplish with hip preservation surgery? Well, I like to think of hip pathology in two different tables or columns here. We think of it as a static and dynamic mechanism. So using the two most common diagnoses in hip preservation, hip dysplasia would be an example of a static pathology, and then hip impingement or femoral acetabular impingement is an example of a dynamic pathomorphology. When we think about what we can do for these two diagnoses of FAI and dysplasia specifically, we really have limited tools at our disposal. So we can correct pathomorphology, we can change the shape of the joint, we can realign malalignments, we can repair, augment, or reconstruct soft tissues like the labrum, and we can address cartilage damage. But for this last category, we really don't have a very good fail-safe way of repairing cartilage once it's damaged or lost. So taking hip dysplasia, which is defined as a lateral center edge angle less than 25 degrees, as an example of the static hip pathology, the gold standard treatment for this is periacetabular osteotomy, which is performed with a series of osteotomies around the hip socket, which then allow us to move that socket into a better position. The goal of the PAO is to cut this acetabular fragment completely free from the rest of the pelvis, rotate that fragment, and that will then provide more coverage to the femoral head. And then as far as femoral acetabular impingement and dynamic pathology, this can include multiple types, including CAM type, pincer type, and subspine type. In each of these impingement pathologies, extra bone only becomes a problem with motion of the hip. And femoral acetabular impingement can be isolated CAM, pincer, or subspine, but it can also be any combination of the three of these things. So the treatment goal with femoral acetabular impingement is to remove the femoral impinging bone when it's CAM type impingement, to remove excess acetabular pincer type impingement, and then in subspine to remove that prominent AIIS subspine bone when that's the source of impingement. Now, another situation in which hip preservation can be useful is with femoral version abnormalities. So we consider normal femoral version to be about 15 degrees of anteversion. And so the treatment goal with derotational surgery is to restore the femoral version as close to what is considered normal as possible. And so the foot progression angle walking test is a quick way in clinic that you can assess a person's rotational alignment. This is called the foot progression angle walking test, and you can watch them walk, either whether they're in-toeing or out-toeing. You can also then ask them to purposefully turn their toes in or out and see if that replicates the pain. If you ultimately diagnose somebody with a femoral version abnormality, we can correct this with a femoral derotational osteotomy using either an intramedullary nail and saw, an osteotomy with a blade plate. You could do a subtroch osteotomy and put a plate in place, or even a distal supracondylar osteotomy with plate. And in each of these situations, increased retroversion is corrected by rotating that distal fragment internally, and increased anteversion is corrected by rotating the distal fragment externally. And again, our goal is to achieve that 15 to 20 degrees of femoral anteversion. So now let's move on to the question of when is it clearly not right for hip preservation? And this is a quick section, but one of the clearest contraindications is advanced hip osteoarthritis, no matter the age of the patient. So we know that patients with osteoarthritis don't do well after hip preservation, and they will ultimately go on to need a total hip replacement at some point at a pretty unacceptably high rate if they have osteoarthritis to begin with. So these are where symptoms can help us differentiate hip osteoarthritis from other forms of hip pathology. And classically, patients with osteoarthritis will describe that achy, constant pain at rest, startup pain, the first few steps being more painful than after they warm up. Whereas pain associated with a diagnosis such as FAI are more mechanical. So sharp anterior groin pain with very specific movements. Most often they describe with deep flexion, internal rotation. Pain is often not constant, and they don't typically feel pain at rest. So now let's move on to the section where there are situations where we can't know for certain whether hip preservation is going to help us or not. And so this is important to keep Brian Kelly's 4-layer concept of the etiology of hip pain in mind. So layer 1 is described as the osteochondral layer, layer 2, the capsulo-ligamentous layer, layer 3, the dynamic or musculotendinous layer, and then layer 4, the neuromechanical layer. And so this imagery here just lets you imagine the very complex potential pain generators around the hip that might not actually be addressed with hip preservation surgery. So keeping this in mind is extremely important. And when we work these patients up for the cause of their pain, I like breaking it down into this very simple 3-step approach. First, you want to confirm that the pain is actually coming from the hip. And then in step 2, once we know we're actually dealing with the hip, we need basic imaging to describe which hip pathology might be causing the pain. And then when you get to step 3, this is when you decide which pathology would be treated and how. And this is where advanced imaging or injections can be helpful. And in reality, the list of diagnoses in step 2 is probably much more extensive, as are the hip preservation treatment options. So we talked about diffuse osteoarthritis, and that is a contraindication to hip preservation surgery. But what about focal cartilage lesions? So a focal, relatively small osteochondral defect can be treated with an open surgical hip dislocation and an osteochondral allograft transplantation. So this is a case of a 30-year-old male. He presented with hip pain and had an osteochondral defect. He had been mistakenly diagnosed many years prior with avascular necrosis and had been treated with a core decompression that didn't work. So for him, I performed a surgical hip dislocation and osteochondral allograft transplant to the femoral head. And so here you can see 1 year post-op, a resolution in that osteochondral defect after that Oates procedure. Now, so far, we only have small case series that show that femoral head mosaicplasty has promising results, but people have identified that perhaps 2 centimeters squared is the largest lesion that you can treat by this method. In the knee, we know that Oates survival rate has been shown to be as high as 85% at 10 years, but we don't know how this translates to the hip, especially considering that in the knee, oftentimes the Oates is being paired with some sort of offloading valgus or varus osteotomy. We don't have that option in the hip. Now, this one case series found that graft survivorship of femoral head Oates was up to 86% at 2 years, 67% at 9 years. But again, they were looking at very small, less than 2 centimeters squared lesions of the femoral head. And then that patient that I showed you earlier with these fantastic looking post-op x-rays at 1 year came back to my clinic at 2 years post-op. He had developed some heterotopic ossification, which was likely asymptomatic. And the head still looks great, but he had this unrelenting arthritic sounding pain. And he ultimately, at age now 32, went on to get a total hip replacement. Now, another diagnosis which can be potentially treated with hip preservation is coxa profunda, or an overcoverage of the hip socket. The surgical hip dislocation was initially the gold standard treatment for femoral acetabular impingement. But now that we have such advances in hip arthroscopy, we really don't do surgical hip dislocations very often. But you can imagine that coxa profunda might be one of those diagnoses that this is the procedure you can use to treat it. So here's an example of a patient who presented with right hip pain, coxa profunda, diminished femoral head neck offset, and then also a labral tear. And so we performed a surgical hip dislocation, and at this point chiseled away the extra acetabular rim, performed an open cam decompression, an open labral reconstruction with tibialis anterior allograft. And then you can see postoperatively a resolution in that constrainment of the joint. And this patient went on to have improved hip function, improved range of motion, and is a roller derby athlete. Interestingly, not symptomatic on the left side, though it looked quite similar to her right side. Now, another gray area of hip preservation is with SCFE or Perthes, which are known pediatric diagnoses which can result in early hip arthritis. So in SCFE, the femoral head metaphysis translates anteriorly and externally rotates within the femoral, while the femoral epiphysis remains seated in the acetabulum and then falls posterior and inferior to the translated metaphysis. So in some instances, with this secondary cam formation, so it's not actually a cam, it's actually the femoral neck, but we can use a hip arthroscopy in a less severe deformity or an open hip preservation procedure in a more severe deformity to correct this deformity of the femoral head neck junction. So in this case, for example, this was a 20-year-old female, and this was her presenting radiograph, and I performed a hip arthroscopy to give her the radiograph on the right. So she didn't need any type of osteotomy of the femur. But take this example of another SCFE hip. So this patient initially presented at the age of 15 with a SCFE, slipped capital femoral epiphysis. At that time, he underwent in situ pinning. And then over the years, he continued to have pain and a development of that secondary cam deformity. So one of my partners here performed a surgical hip dislocation, open cam resection, labral repair, relative neck lengthening, and then used an allograft wedge to create space in that greater trochanter. And so now at this point, this patient's 17 years old. He's undergone pinning, removal of screw, open surgical hip dislocation with femoral osteoplasty, labral repair. And despite this, he continued to deteriorate his hip joint. So you can see active osteophytes, regrowing that cam-type deformity. And over the years, he's now ended up with an arthritic hip. And at the age of 23, we don't have any hip preservation options left for him. So he's a patient that's going to need a total hip replacement. Now, there are additional procedures that can be attempted for SCFE, such as the modified Dunn. And this is an example of just one of the very intricate hip preservation options that can be available for adolescents with SCFE, but they're quite involved. And they can result in outcomes such as this with avascular necrosis of the hip, which in an adolescent is a very bad problem to have. Now, multiple studies have shown that the longer the duration between SCFE pinning and a hip arthroscopy, the worse the cartilage wear. And that was the case in that 20-year-old. She had grade 4 cartilage wear in her hip. So one solution could be that maybe after every SCFE pinning, we prophylactically do a hip arthroscopy. So I'll just float that out there, and then we can come back to it later. So another challenging diagnosis to deal with is Perthes. So Perthes is an idiopathic osteonecrosis or avascular necrosis of the femoral head epiphysis. This was independently described by 3 separate individuals in 1920. And this is an example of a 30-year-old patient who presented to my clinic, and he has many of the classic adult sequelae of undiagnosed Perthes. He'd never been diagnosed with Perthes before, but you see he has coxa magna, trochanteric overgrowth, coxa brevis, and acetabular dysplasia. And so in this patient, given that MRI showed he had excellent articular cartilage, we performed a surgical hip dislocation, open femoroplasty, relative femoral neck lengthening, and a concomitant PAO, all in the same surgical setting. And with that open cam decompression at the same time, now he has the ability to move this hip very well. But here's another patient with Perthes. So she presented to clinic. She's a 27-year-old female. And you can see that this central area of her femoral head has a very large osteochondral defect. So that procedure that I just described in that other Perthes patient is not likely going to offer in her any improvement in symptoms because she has an area of femoral head arthritis. And so for her, our recommendation was to actually go on to a total hip replacement. Okay, so even in the seemingly more straightforward diagnoses, the limitations of hip preservation surgery are very important to consider on a case-by-case basis. So looking at this patient's right hip, most surgeons would say she has too much joint space for a hip replacement. So she's a candidate for hip preservation surgery. She's got very clear dysplasia or undercoverage of that femoral head. And her cartilage looked pretty good on MRI. She did have some small areas of subchondral cystic changes. So the answer is periacetabular osteotomy, the gold standard for dysplasia, right? Well, and you could say, well, with labral pathology, do a hip arthroscopy at the same time. And I would say vast majority of my PAOs I'm doing with the hip arthroscopy. This is the table, the postless traction table. So you can see I put in a foot extender, take the feet out of the boots, remove the legs of the table away from the table. This is my hip arthroscopy drape. So you can see the blue arrows show you my hip arthroscopy portals, and then this orange arrow is showing you my planned incision for the PAO. And everything's just ready to go. So you move from one right into the other. But what if I then tell you this patient that we're talking about is actually 51 years old? She's already had a left hip replacement because she was previously dysplastic on that side too, and the cartilage was more far gone. So now what do you do? Well, taking into consideration one of the most common complications after PAO in older patients is a non-union, as seen in this 42-year-old female. The non-union most happens here at that pubic cut and can result in stress risers elsewhere. So she had developed an inferior pubic ramus stress fracture. And if a non-union occurs, again, this is more likely if the patient's over the age of 35, the subsequent treatment is bone grafting and plating of that non-union. And I'll tell you, in this patient, after that second surgery, she was wishing she had a hip replacement instead. So I think this is something that you have to factor in. So back to our 51-year-old patient, she has a higher likelihood of complications and non-union with that periacetabular osteotomy. And so she decided to just get another hip replacement in that right hip. So now let's move on to the big picture limitations in hip preservation. So first, let's talk about the losing battle against the hip replacement surgery. So hip dysplasia is one of the leading causes of early arthritis. Up to 40% of all patients getting a hip replacement have underlying dysplasia. Similarly, femoral acetabular impingement is one of the leading causes of osteoarthritis. And so it goes without saying that patients with the diagnosis of hip dysplasia or femoral acetabular impingement may ultimately have osteoarthritis that they need a hip replacement for. So here's one reason why I find standing films over supine AP pelvis films very helpful. So this is a 50-year-old patient who came to clinic with the x-rays on the left. She had good joint space, 50 years old, potentially a candidate for hip preservation surgery. I got a supine film. This is less than a month after her, I got a standing film less than a month after her supine film. And look what happened to her joint space. It's completely obliterated. So in this 50-year-old patient, she went on to get a hip replacement. Now, it's also important not to miss what we call occult arthritis. So the x-ray may actually appear to be normal, might have good joint space even on a standing film, but then you get an MRI and the patient has subchondral cystic changes, which may be only apparent on MRI, but this is not a patient who will do well, especially with the femoral head changes after hip preservation surgery. So the hip replacement surgery, as we know, has been coined the operation of the century. This was by Lancet in 2007. And certainly the benefits of a hip replacement include that it's a one and done procedure. The surgery itself is much faster than a hip arthroscopy or hip preservation surgery. Basically, all sources of pain are addressed. The labrum, the cartilage, dysplasia can be addressed. So we've also seen this shift in younger hip patients getting replacements. We have the advantage of robotics. Advances in implants and technology mean that these implants are lasting for longer. So why shouldn't everybody get a hip replacement? So as successful as that hip replacement is, there are a certain percentage of patients who still have dissatisfaction and persistent pain. And components do wear out over time. And then that revision hip replacement surgery is not as straightforward as a primary hip surgery. So the decision really should be made on a case-by-case basis. And I kid with my arthroplasty partners that they can either do demolition, which is the total hip replacement, or we can do the detailing, which is hip preservation. So next, the big picture limitation that I'd like to talk about next is that learning curve of these procedures. So I went back to PubMed and found the learning curve of a few procedures that had been published. So these are just a few of the ones that came to the top of the list. So robotic hip replacement, we think the learning curve is about 14 to 35 cases. Total ankle arthroplasty through a transfibular approach, probably about 16 to 20 cases. A reverse total shoulder arthroplasty, the learning curve is about 40 cases. That's a complication-based learning curve. Direct anterior approach, total hip arthroplasty, considered one of the harder approaches to a total hip replacement, about 43 cases. Periacetabular osteotomy, about 20 to 50 cases for a learning curve, although there's been published literature showing that a 1-year hip preservation fellowship at a high volume center can result in complication rates consistent with an experienced surgeon when that person graduates from a hip preservation fellowship. And then hip arthroscopy, universally thought of as one of the most technically demanding steep learning curves, about 519 cases. In one study, the authors found that failures of less than 10% only happened after the surgeon had performed over 388 cases. And you have to have over 519 cases in your career to lower your complication rate significantly. So with learning curves this high, there's a significant bottleneck in learning and becoming adept with these procedures. It's also, as the residents and fellows know, a very challenging procedure to teach. And lower volume hip arthroscopy surgeons do have higher rates of revision, major complications, longer operative times, and higher readmission rates. And what defines a low volume hip arthroscopist? Well, some say that it's those performing less than 30 hip arthroscopies per year, and others say it's those performing less than 102 cases a year are considered a low volume hip arthroscopist. But it actually looks in national databases like most of the surgeons in the United States performing hip arthroscopy are performing less than 30 cases per year. So this might beg the question, well, if low volume surgeons are doing worse, should they just be referring to high volume surgeons? And this is actually Dr. Zhang's study and Dr. Wong's study here, looking at a national database. It does seem that we are plateauing as far as the numbers of hip arthroscopies that we're doing over the years. And so I don't think it's a possibility for everybody just to refer. So it does seem that those higher volume surgeons are performing surgeries on younger patients, and then lower volume surgeons are performing hip arthroscopies on older patients, which is probably appropriate considering failure rates resulting in hip replacements. But what are some of the solutions? So I believe a big part of this learning curve is being able to identify the correct surgical patient. So understanding the nuances of who's dysplastic, who has acetabular retroversion, who has hypermobility is extremely important. And there are a huge number of radiographic measurements that exist to help us diagnose hip pathology. But because there's no single gold standard measurement, it's really important to pay attention to multiple measurements. And then this is my standard series of radiographs that I get in clinic. So a standing AP pelvis, a 45-degree done lateral, and a false profile in order to be able to see what's going on with that hip joint. And another word on why it's important to get the standing radiographs. You can see here on this supine film, we have what's called a positive crossover sign, positive ischial spine sign, and you stand that patient up, and same patient just moving from supine to standing, and suddenly now there are no signs of what we call acetabular retroversion now that the patient is standing. So for every patient that comes into clinic, this is my grid. I measure everything on their x-rays. And it's not just easy enough to say, measure those measurements. You have to measure them correctly. So here's an example of the same x-ray, and I've measured the lateral center edge angle differently. And you can see it's almost a 9-degree spread depending on where you draw that lateral line. And I would argue, in my opinion at least, this is the most accurate way on the far right to measure this patient's lateral center edge angle. So really becoming adept with how you measure these x-rays is a huge part of the learning curve for hip preservation. Spending time in clinic learning how to diagnose if it's actually the hip will also help with the learning curve. So the hip is probably one of those joints that has the broadest range of pain locations compared to any other joint. And the patient's history is incredibly important. I can't tell you how many times a patient will come into my clinic and describe their hip pain as they trace out the exact dermatome of L2, L3, L4, all the way down the leg and around the hip. So I think, this is really important to listen to the patient, to watch where they describe their pain. And then, of course, provocative tests will help you isolate the diagnosis. But it's also important to know that there's an extremely high rate of asymptomatic labral tears. In young adults, it's up to a 70% prevalence of asymptomatic labral tears when patients have absolutely no hip pain. And this is in patients in their 30s. And then once patients get to over 50 years old, 93% with zero hip pain will have some labral pathology on MRI. And this is in contrast to pediatric patients where that number has been quoted to be about 1.4% prevalence. So very different in adults. There's also a really high incidence of asymptomatic radiographic femoral acetabular impingement. So 37% of the population will have a cam deformity on X-ray with no hip pain. And when you look at the athletic population, that goes up to about 55% of athletes will have asymptomatic cam morphology. So here's where advanced imaging can really help us identify what is going on with these patients. This is a low-dose CT scan, and you can see that this is showing us a cam lesion on the femoral head neck junction. This is a CT scan showing us a pincer lesion. So they give us a heat map of where that extra prominent bone is. And then here's a patient who has subspine impingement right beneath that AIIS, and showing us what's going on with that hip as well. And then in some patients with focal acetabular undercoverage, you may not completely understand how undercovered that hip is until you get a 3D CT image. And here you can see basically the fovea of the femoral head, which you might not have expected to see based on the x-rays alone. Now, what are the concerns with obtaining CTs? And I get 3D CTs on every single patient. Well, of course, radiation and the utilization of extra resources, the question of whether or not it's actually necessary in these patients. But this recent study showed that this low-dose radiation protocol offered a 90% reduction in radiation exposure compared to traditional CT. And it's about the same as 2 standard hip radiographs that you're getting, or 1 single cross-table lateral radiograph. That's the entire amount of radiation with that CT scan. So I think with all the information it gives you, it's in my opinion, worth it to be treating these patients correctly the first time. Acetabular version measurements can be obtained on the axial cuts of the CT, and then we can do femoral version measurements, and we've now started obtaining tibial torsion measurements as well from these pre-op CT scans. And then diagnostic injections can be really helpful in honing in on the etiology of pain at each step of these diagnoses. Now, another way to overcome the learning curve is to keep learning. So through courses, webinars, articles, lectures, and meetings. There's also interest in virtual reality learning to improve especially hip arthroscopy skills. And another big way to overcome your learning curve is to follow patients closely. So this is where patient-reported outcome measures come in. PROMs, PROMs are necessary to truly understand how we're doing and whether patients are actually getting better after these surgeries. So I like this quote from Dr. Stedman: if a patient does not think he or she has a great result, then he or she does not. As we know, collecting patient-reported outcomes is a lot of work, but it really gives us answers to our clinical questions. It results in modifications of surgical technique, and it can change our practice. But there's no gold standard of patient-reported outcomes that we collect, especially in hip. There are more than 20 different patient-reported outcome measures in hip literature, and most publications are using an average of 3.2 different PROs per publication. So I began collecting patient-reported outcomes my very first day of clinic. I actually printed these pieces of paper out and handed them to patients and then transcribed them into REDCap later. And we've moved on to electronic and computer-adapted testing patient-reported outcome measures as well. But I wanted to bring up some of these questions and controversies in hip preservation that we have been able to solve simply by collecting patient-reported outcome measures. So initially, we debrided the labrum in hip arthroscopy, But we found that patient-reported outcome measures showed that patients did better with labral repair. So that is now our standard of care. Then the question of labral repair versus labral reconstruction came about. And the authors of this publication found no difference in patient-reported outcome measures and the proportion of patients achieving clinically significant outcome. So this supports that we do what is best for the patient, either repair or reconstruction on a case-by-case basis. Iliopsoas release was also a common technique in early hip arthroscopy, and this recent multi-center study demonstrated that patients had poorer outcomes after iliopsoas release, and so they concluded that we shouldn't release the psoas tendon. Another technique question was whether to perform a chondroplasty or a microfracture for full thickness cartilage defects in the hip. And with similar patient-reported outcome measures, the conclusion I've drawn is we should be doing the less invasive procedure, so performing a chondroplasty instead of a microfracture in the hip. And multiple studies have looked at whether closing the capsule after hip arthroscopy affects outcomes compared to non-closure of the capsule. And a growing number of studies have really shown superior patient-reported outcomes after complete capsule closure. So now we close the hip capsule. Patient-reported outcome measures also allow us to answer questions like, how long does it take for a patient to get better after hip arthroscopy? And in this paper, the patients tended to have most improvements by 3 months, but they can continue to improve for about 2 years after hip arthroscopy. So this helps us counsel our patients. And there are a number of multi-institutional consortiums which collect the same patient-reported outcome measures, and then we can combine them across multiple institutions. And this allows us to come more quickly to conclusions about what interventions in hip preservation are working, who's doing better, and why. And Wisconsin is now part of the Anchor network, which really helps us consolidate those patient-reported outcome measures. So the final limitation in hip preservation surgery has to do with diversity, equity, and inclusion within our field. And we spoke about this morning with the residents when we talked about mentorship, sponsorship, and advocacy. But for the larger crowd here, 70% of patients across the United States who are getting hip arthroscopy are female. And females are also twice as likely to have hip dysplasia than males. And we really only know about these differences in female and male hips in the past decade. So it was only in 2016 that the NIH required sex to be an important biological variable. So before 2016, it wasn't required that we even had to report on the differences between males and females. So our current long-term data on hip arthroscopy doesn't include the nuances in how these hips are different. And despite hip preservation patients being mostly female, we know that orthopedic surgeons are mostly male. So orthopedic surgery, in fact, has fewer females in the field than any other subspecialty in medicine, including neurosurgery, urology, or plastic surgery. And why then is this discrepancy especially important in hip preservation? Well, a number of articles have recently found that negative patient outcomes, including complications and death, are related to the sex discordance of the patient and his or her treating physician. So what this means is that if the surgeon is male and the patient is female, which is the most common sex discordance we're going to see in orthopedic surgery, that female patient has worse outcomes. But interestingly, these studies found that if the sex discordance is reversed, so the female is the surgeon and the patient is a male, that you don't see those discrepancies in outcomes. So in hip preservation, I'm often the only female surgeon presenting at our hip preservation meetings, conferences, or webinars. So even within hip preservation, we have fewer female surgeons than even in sports medicine as a whole subspecialty. This has been changing over the past few years, though. So I've definitely seen more. Dr. Wong and others are up there on the podium with me nowadays. So I've really appreciated, even a few years, a big change in the right direction. And why is it, you might ask, that in hip preservation, fewer females are going into this field? Well, one is certainly the radiation that we have to use in hip arthroscopy. I just got these sleeves added to my lead. These sleeves protect breast tissue that goes up into the axilla. And so not as much of an issue for males, but in in females, all of our standard lead was made for a male body habitus. And so the arms are cut out, exposing that breast tissue. So this is something that we can do to mitigate it. I use lead glasses. I use lead-lined gloves as well. And then there's also the question of physicality. So especially procedures like the periacetabular osteotomy, we're osteotomizing the pelvis, we're malleting, we're sawing, we're drilling. And of course, if you look at, this is a picture of me in residency, standing next to my trauma attending. And you can see he's got a slightly better lever arm for some of these procedures. But in reality, these days, all of you who are in orthopedic surgery would agree that physicality doesn't really prevent us from doing the surgeries that we need to do. We have such amazing tools, instruments, and assistants that we really don't need to worry about that. It's also especially important to do outreach and bring more females into not only orthopedic surgery, but hip preservation. We can do this through participation in initiatives like the Peri Initiative, teaching at courses. I do a monthly hip preservation podcast with the Arthroscopy Journal. Both Dr. Wong and Dr. Zhang have been guests on that podcast. And I think just, being there to teach the next generation is really important. So here I'm going to bring back my disclosure slide. So this study up here looked at the representation of females on editorial boards, and the authors found that women make up only 9% of orthopedic journal editorial boards compared to 21% of general surgery and 35% of internal medicine. Now, much of our medical research, as we know, is based on males, and it's generalized to all adults. And studies have shown that when clinical outcomes in women differ from those in males, they're often actually just disregarded, not published, ignored. And we know that research conducted in women is far less likely to be published than the same research conducted in men. Female researchers themselves are more likely than males to report by gender and sex. And maybe that's changing a little bit now with the NIH initiative to include sex as a biological variable. But because orthopedic surgery has the least female physician representation in all of medicine, you can see how the discussion of the female hip preservation patient likely doesn't get the airtime that it deserves. So one solution certainly is that as a group of underrepresented individuals in orthopedics, women specifically, we need to not only write more papers, but we need to review those papers. And for me, this usually happens after kids' bedtime. So this is why my only hobby is checking into restaurants on Yelp. But studies have also shown that having a role model of the same gender or ethnicity is much more important for females than it is for males. So mentorship, sponsorship, and advocacy, which we spoke about this morning, is incredibly important, but especially for females in medicine. So in summary, while hip arthroscopy can accomplish much, and arguably more and more is becoming possible with hip arthroscopy and hip preservation surgery, patients can still have continued or even worsened symptoms from a poorly indicated or poorly executed hip preservation surgery. And when thinking about the open hip preservation alternatives to hip arthroscopy, we need to keep in mind that these are large procedures. They're often more clinically technically difficult to perform and more difficult to recover from for our patients. Patients can continue to have pain, a protracted recovery, or complications such as the non-union and periacetabular osteotomy. So in many of these cases, even though we might want to try to preserve a hip, it's a challenging decision as to whether it's worth it or whether we should refer to our arthroplasty colleagues. And as far as the big picture limitations in hip preservation, there's no doubt that the hip replacement surgery is a very good option. And in fact, it might actually be better in cases of really challenging hip problems. The learning curve in hip preservation is incredibly steep, especially for hip arthroscopy, but dedicated hip preservation fellowships and training in sports medicine fellowships can really help this learning curve. Patient-reported outcome measures. They require hard work to collect, but they're necessary for our improvement, to treat our patients better and to become better surgeons. And we all need to continue to increase the diversity in orthopedics and especially in hip preservation surgery. We talked about this earlier. This is orthopedics and representation of females in orthopedics. And you can see we are the bottom of the barrel when it comes to medicine. So something we can all continue to work on. So thank you again for having me. It's been such a pleasure talking with you, and I'll take any questions that anybody has.
All right. Thank you, Dr. Spiker. That was fantastic. And thank you for the great case conference yesterday, the mentorship talk this morning, and really appreciate you coming out to visit. I see Dr. Diab's hand up, and then over to Kaz as well.
Thank you. It's been nice to get to know you a little. I sit between Dr. Bervin, one of our senior spine surgeons, and Dr. Morshed, one of our trauma surgeons, leads that service, and from whom I have learned so much over the years. And you have been able to bridge arthroscopy to open. I think that's great. You know, the pressure on us is to specialize and specialize and specialize, but we need a little bit of breadth as well as depth. So I mean, it's just impressive to watch. It's pretty great. And I think your contributions will show it. I tried yesterday to float a theory by you that you weren't impressed by. So I'm going to try a second time with another theory. I've sort of, when I was in residency, I'd never heard of FAI. It didn't exist. It's a little bit like the MPFL, but I've learned to embrace it. And now I replace MPFLs and I recognize FAI. And in my residency, I never saw hip arthroscopy. In fact, the first hip arthroscopy I ever saw was the one I did in my first year of practice. And it took me hours to do. And I'm not sure I accomplished anything. But one thing I learned in residency is hip dysplasia and Shenton's line. And I just would like to make a proposal to you. I saw your diagram of hip dysplasia as static and FAI is dynamic. Could you consider that there probably are some patients where hip dysplasia is dynamic? So in the pediatric world, we talk about Shenton's line being interrupted. We talk about subluxation, and the most extreme is dislocation. You're not going to have that in the adults, but I learn a lot from, as you do, from lying down versus standing up images. And when the hip shifts between the two, that says to me there's a bit of a dynamic component. And the reason I'm asking about this is I've had so many failures with PAOs. I do a nice job, and they're young, and I'm not quick to act, and sometimes they just don't get better. Do you think that there's at least a component of those patients where there's a dynamic problem that we can't measure? We don't have a dynamic test. And unlike the knee, where we're pretty good at learning about motion and the shoulder, we still think of the hip as this block encased in muscle, way deep, difficult to sort of appreciate dynamically.
Yeah, thank you for that question. Yes, I'd be willing to consider it, but I'm going to pose another question back to you. So upwards of 90% of patients with hip dysplasia have femoral acetabular impingement. So is it not that hip dysplasia is dynamic, but that they have a dynamic pathomorphology occurring at the same time?
I agree with that. That's why I now think of hip dysplasia as more encompassing. I don't differentiate it. I don't differentiate sort of the uncovered hip as hip dysplasia and FAI as FAI. I think that's where you come in. That's been sort of the sports world, even though Gans and company came up with the concept, the sports surgeons have really taken that on. And I think that the division's artificial. I agree with you. I think they're probably under the broader umbrella. And it's going to take people like you who do both to sort of bring them together.
Well, and one thing, I don't do arthroplasty in my practice, and I think this looks toward the European model where surgeons focus on a joint. And so I think this is interesting. Speaking of Gans and the Swiss surgeons, for example, they span the spectrum. They are a hip surgeon, so they'll take care of pediatric dysplasia, SCFE. They do arthroscopy, they do periacetabular osteotomy, and they do hip replacement. And so I think that's a very interesting model. And I miss having that ability to do hip replacement in my practice in some instances. But I do think having the ability to do more than just one thing is very helpful.
We'll go to Dr. Casalino next.
Hi, I'm Kaz. I'm one of the residents. I was curious to see what your thoughts are on hip resurfacing and what its role is in sort of the hip world as you've sort of presented all of it. Is there a role for it?
Yeah, so I get this question a lot from patients. When you say you're not a hip preservation candidate, then they're looking for kind of that next intermediary step before the hip replacement. And so I'm not an expert on this. I don't do hip replacement in my practice, but I ask my arthroplasty colleagues a lot of these questions, and I learn a lot from my arthroplasty colleagues from those patients that we refer to them. And the general sense that I get about the hip resurfacing, nobody is actually doing them at my institution. And one of my arthroplasty colleagues trained at HSS with Ed Sue and says if he ever needs somebody who needs a resurfacing, he'll send him to one of the high volume surgeons. There aren't that many in the nation. And I think in the appropriately selected patient, there's a role. But in general, it sounds like more and more people are just skipping that step and moving on to the hip replacement.
Hi, I'm Sam Morshad. I do trauma here, and I enjoyed your talk. Thank you. There were two things that impressed me. One was this learning curve that you talk about, and it's hard to establish thresholds for this. I published on this in the trauma sphere, and I think I've been appropriately criticized for potentially setting up systems that are serve as barriers to access to care. If you demand that patients, only ought to be treated for their complex acetabular fracture, tibial plateau, or whatever it is, that there are going to be barriers because there are going to be fewer people doing it. And I look at this number of like 519 and wonder how many surgeons in the country do that, have done that many hip arthroscopies, or meet these bars, some of the bars that you may not have set but have been proposed. What does that mean for the latter part of your talk, some of the issues around DEI and serving all people with these problems, if these are in fact effective treatments that we're offering them?
I was hoping somebody would be able to answer that question for me, but I tell the residents and the fellows, I don't think there's anything about hip arthroscopy that makes it impossible for any one person to do. I think it is a lot about sticking it out. And I think for those of us who do hip arthroscopy, I think those numbers feel real. I mean, we do other surgeries too, ACL reconstruction. I don't feel like that number is nearly as high as it is for hip arthroscopy. But it's a challenging procedure, 70-degree scope, a scope that we don't typically use in other joints. And it's requires traction. It's deep, a different type of pinpoint location than we use in other joints. And so I tell my trainees, it's anybody can do it. You just have to be willing to do that, dedicated, concentrated 10,000 hours, as we've heard, for, becoming an expert in something. But I agree. I mean, I don't think we should be out there saying that those low volume surgeons need to necessarily refer. But I think insight is important, and recognizing that this is a procedure that if you appropriately indicate a patient, you understand that this might be a harder hip arthroscopy than the average hip arthroscopy, and you're not quite there in your learning curve. Maybe that's the patient you refer out until you get there in your learning curve. And if you stick with it, there's no reason that you won't get there eventually. Maybe not 519 in a career, but certainly you'll get to a better place along that learning curve than somebody who's just starting out. But I don't know what the right answer is. And I don't think, as a high volume person, I certainly don't want everybody to stop operating out there. I want more people to continue operating to become better.
We'll go to Dr. Emmerman.
Thanks. Thank you very much for your talk. I'm a hand surgeon. I'm doing and learning elbow arthroscopy. And, elbow arthroscopy is another operation that is often quoted to have a very high learning or difficult learning curve. But I have a comment and a question about the numbers you quoted. To me, 500 seems staggeringly high. And I'm wondering whether the studies that are looking at reoperations really just reflect the patient population, that older patients are much more likely and much more willing to have a subsequent operation like a hip replacement, whereas a younger patient is going to be told by surgeons to not do that. So they're going to put up with perhaps than a perfect result for longer. So the number my question is, so the studies I think are, I don't want the residents to take away that they're never going to reach that, because I think that's a disservice, as I think Dr. Morshad also suggested. But I'm wondering if is there any research planned or being done that looks at technical performance, by video, and how long does it take for a surgeon to learn to accomplish specific tasks, enter the hip joint, burr down the impingement, etc., and do that safely?
Yeah, I think more and more, that's an excellent question. I think, again, I don't think we want to discourage people from going into hip arthroscopy. I just spent a few minutes talking about how we need more people to go into hip preservation. But I think recognizing, doing the research first and saying, this is an abnormally high number for this specific procedure. Let's come up with ways that we can make that learning curve more manageable. And that might be cadaveric labs, that can be virtual reality surgeries, that can be technology. So there's technology out there that exists that can help you perform a CAM femoroplasty, and has been shown in some preliminary data to actually improve a novice surgeon's ability to do that part of the procedure, both in speed and accuracy. And so I think, development of methodology in order to help people overcome that learning curve is kind of the next big step. But then patience with our surgeons as it's a race against the technology, who can get there first. And in the meantime, I think just continue to operate is the best way to go.
Hi, thank you so much. That was an excellent talk. I loved every part of it. I really appreciated where you showed what we've learned based on the evidence. I thought that was really interesting, and the changes you've made based on the evidence. But my question is actually about the last part of your talk. It strikes me that not only in editorial boards, but also things like implant consulting or medical legal work, or a lot of these kind of extracurricular activities that take a lot of time, but also maybe carry prestige, maybe carry other financial incentives. I do think there's a gender difference, and not just based on the low number of women in orthopedics, but even so, there's fewer than you would expect. And just speaking for myself, it's all I can do to take care of my patients and my responsibilities at the university. And when opportunities like that come across my desk, I never say yes. I mean, I just said no yesterday. It's like one more thing I can't do. So what can we do for our trainees, for young women faculty, to make that a path that they can do? If you are interested in medical legal consulting, this is how you do it. If you're interested in implant design, this is how you do it. If you want to be an editorial board, because I think there's just so many other factors that may be getting in the way of women knowing they can or should or think about doing that.
Yeah, thank you for that question. And I think we have to be very purposeful about it. So, from personal experience, a lot of the ways that you get involved in reviewing for a journal the first time, or being involved as a paid consultant for industry, it's all who you know. And unfortunately, in orthopedics, a majority of who is in orthopedics, 93%, are males. And so if males are being asked, do you have a co-resident, a fellow, a friend, a colleague who you want to invite to review for our journal, more likely than not, it's going to be another male. There's just more males in the field. And so, so I think that's probably one reason why we've seen that trend. But I think being very purposeful about it, and this comes from, the leadership of the journals, the leadership of industry, to say, we need to seek out more females, because then those females are going to say, I want to ask my colleague, my friend, who is another female, to join us on this, to review for these articles or be a part of the industry group as well. So I think being very aware of how things kind of fall into place, and then actively trying to change that is probably the best way to go. But you're absolutely right. I mean, it takes a lot of time away from responsibilities. But the nice thing about all of those things is that when you get involved, I think you do have control. I mean, you can say yes to certain articles, no to review others. You can participate as much or as little with industry as you want once you become a consultant. And so I think knowing that when you say yes, you still have power is important as well.
All right, just wanted to say last thank you. We're right on time here. So thank you, Dr. Spiker, for coming out and giving an excellent couple of talks for us today. Really appreciate that.